In this chapter, we will be covering diagnosis. Diagnosis means, how do I find out what the patient wants? How do I find out what I can offer him? To do this, we need to train our eyes. In simple terms, we have an initial situation we need to find out. What is wrong? And that in a short space of time. One imagines what the lips look like. Look at the contours of the lower and upper lip. How are the lower teeth? And then one sees that we're dealing with an inverted occlusion level. We therefore need to imagine that the teeth would be somewhat longer in the correct position. One creates an image, slowly projects the situation, and then prepares it temporarily with composite. As a rule, one uses composite material directly on the tooth, without conditioning it. This takes approximately 10 minutes. One applies the composite to the surface and can present the result to the patient immediately. The patient can see in which direction we could be going. And at the same time, I receive information. Is that right, what I suggested, and is it possible for me to deliver? Again, slight malposition on the one side and somewhat larger triangles. One imagines the teeth in ideal position in the row of teeth, also in the correct proportions. One conveys this vision to the patient and can show him right away. Therefore, it is recommended to take photographs before and after the application. If you have the facilities, print out the photo. A photo printout can be exceedingly helpful for the patient's decision-making process. Here too, we have an inverted smile line. That means the individual front teeth, the middle ones, are a bit too short, and the 2 is shifted palatinal. This results in a large triangle. By bringing the 2 forward, lengthening the 1 somewhat, and imagine this virtually in relation to the upper lip, you immediately get a different impression. And the patient gets this new impression too. That means he knows, aha, that is possible, I can have that. Also in this case, a diastema, it is irritating because we cannot see the color shades so well. But the contrast even better. That means we have a dark oral cavity, or in this case the lip and the tongue, which forms a contrast in the background against the teeth. And this results in a triangle. We have a diastema and again a step. Just by correcting these small regions with a little composite, you get a completely different impression. This means the smile is completely different. In this case too, we have the lip contour. The teeth are actually slant to the occlusion level, and again we have this pronounced contrast line. If the contrast is broken with a little composite, we get a completely different picture. This can be practiced on the patient. At first, one can also resort to using a model and apply composite on a trial basis to find out how it could be modeled and then presented to the patient. Diagnosis also has another reason. Often, there is a fear of making changes to front teeth because people believe they must be ground. They have heard of crowns and veneers and always have the feeling, oh dear, a lot needs to be ground away to get beautiful teeth. However, if one can show the patient how the optical impression can be changed completely by using only 2 or 3 portions of composite on the surface without conditioning during diagnosis, then this helps to gain the patient's confidence in this system. Especially if I can tell him or her it can also be done with no or little preparation. The patient appreciates that as I perform the diagnosis without conditioning, without grinding, I place the composite in the interdental space, close the optical triangle to the cuspid, and immediately things look completely different. The facial expression, the smile, everything changes. This often happens in situations where patients think that nothing can be changed. We can see the lateral incisors protruding like elephant tusks, if you like. We also see the central incisors, which basically have the correct length if the occlusion level is shifted up to the cuspids. The lateral incisors are simply a bit too short and twisted. If the lateral incisors could be made longer, and if I could bring the central incisors forward, then things would be better. If I imagine a continuous line, then the situation changes in minutes. Here again we have the contrast points, the interdental gaps, the triangles. One imagines how the tooth profile would look without this gap. In principle, the line is correct and is harmonized to both the lower and upper lip. Or also in this example, we can see the curve of the upper lip, but the curve is not displayed on the front teeth. The front teeth have been abraded here. In other words, they do not correspond to the lip profile nor the occlusion level. This means certain teeth need to be extended, and then, as a result, the upper lip profile will correlate to the incisors. In this case too, we can see the palatally shifted lateral incisor. This is basically the main reason why the patient is unhappy with his front. And on the other side, we have a lateral incisor which is too short. That means we have this disruptive optical end-to-end hole. Harmony is achieved by moving the incisors somewhat to the front. And at this moment, one can see that the lower jaw requires a little bit of grinding. This means the incisal edges of the lower incisor need to be polished slightly in order to shift the lateral incisor into the right occlusion, so that the overjet is corrected in the end. This example shows teeth which are all inclined palatally at a very steep angle. This makes for a narrow mouth optically and gives a grim impression. All these cases are actually quite nice and illustrate the problem. Just imagine the dental arch somewhat rounder. This means applying some composite. This makes the dental arch somewhat rounder and the teeth are straight. This effectively demonstrates to the patient that preparation is not required. At the same time, I can see that I do not need to perform preparation. Diagnosis has shown me where I need to prepare, if at all, or how to correct the axes of the teeth. In other words, where to start and how to place the componeer shell in order to finally correct the axis of the tooth. In this case, the central incisors are relatively long. If the axes are corrected, they will appear even longer in some places. They therefore need to be shortened slightly to achieve a certain harmony. In this example, we can again see the contrast line between the upper incisors and the lower lip. Everything looks a bit busy. The dental arch can be rounded somewhat by simply applying composite. But the teeth are not all in the same position. If they can be aligned with slight coating and by correcting the incisal edge toward the lower lip, then everything looks considerably more composed. In the end, it's all about imagining a balanced picture. So you ask yourself, what is wrong? In most cases, it is the contrast line. It is rarely the wrong color of the teeth. Usually, it is the contrast line or the contrast situation, for example, in case of missing teeth. Disorderly teeth often also visually reflect a certain degree of insecurity. Looking at the smile on this face, one gets the impression of seeing an insecure person. One is led to believe the person is insecure. If one can remedy this contrast situation, things look different. The smile acts differently, or let me put it this way, the person has more personality. There are different types of mouth. Looking at this mouth, one can hardly see any lip contours. There is hardly a lip, optically speaking. At the same time, the teeth are somewhat short, or at least appear short, because they have a very straight incisal edge. This creates a hamster effect, although there is nothing tangible. As soon as you modify the tooth structure, the overall situation is entirely different. The lip contour is still missing, but the teeth can compensate this somewhat in harmony with the gums. In most cases, the objective can only be achieved by complementing, in other words, by adding. And this is exactly the advantage of Componeer. Componeer enables an additive approach. There's no need to first remove tooth structure in order to complete things later. And here's another classical example. We can see the contour of the upper lip and this convex line. At the same time, we have a concave line opposite. Everything looks unruly and out of harmony. Often, patients do not know what irritates them. They're simply dissatisfied with their front teeth. And it's our job to find out what could be wrong. It's best to let patients talk about their problem first for 1 or 2 minutes. While they're talking, take a look at their teeth and see which anomalies might be present. Do not focus on individual teeth, but try and capture the overall picture. Only then does one notice that the various contrasts or the contrast line are the reason for disharmony, and that this smile is not comparable to the smile of the initial situation. And, naturally, there is also malposition of teeth. This implies that things do not look attractive. On the one hand, we can see a strongly curved lip. On the other, the contrast or brilliance of the lateral incisors is lacking. They are also inclined palatal, which makes them look even darker. The ones and the cuspids, the threes, are extremely noticeable. It looks as if these teeth were in an incorrect position. In the end, it is the 2 lateral incisors that are out of line. As soon as this row of teeth is rounded off, the gummy smile is alleviated. Gummy smile means that we see relatively too much of the gum in relation to the front teeth. This is because the presence of the front teeth is somewhat diminished in the overall picture. As soon as the presence of the teeth is shifted forwards more, then the impression of profuse gums disappears. In this example too, the massive contrast line as well as the gaps which appear when laughing. This makes things look very dark, and the gums are also slightly inflamed. One can also see that the teeth are somewhat long. If one wants to harmonize the appearance, then in the end one also needs to design the front teeth a bit shorter. Otherwise they would appear too long in relation to the occlusal line. The dental arch would then appear too round or bow-like, because the upper lip is not lowered enough as to require making a curved dental arch. It's always the same, also in this case. We see a straight upper lip and frayed front teeth. And again, we see the contrast line, which is in absolute disharmony to the upper lip. We can also see the fours, the premolars, which are somewhat inclined, as well as the two incisors at a very steep angle. Here you need to imagine an overall picture as to how this line could harmonize with the upper lip. One applies the composite and can already present the patient with a possible outcome. The diastemas, the gaps, are of course extremely prominent. These gaps can also be closed. It is quite easy to demonstrate to the patient how they can be closed. Optically, the lateral incisors were arranged somewhat mesial. At first, one might think that the central incisors would be too large when closing the gap. However, when the teeth are arranged buccally, then I can shift the margin line inward and thus shift the lateral incisors, the margin line, to mesial. This allows adapting the proportions of the teeth accordingly. However, sometimes the teeth need to be made somewhat longer. This is not a problem here, as they are too short anyway. We need to make them longer and wider to retain the proportions. This is a very important point. This is why componeer are designed as they are. If one measures the componeer precisely, one would find that they comply exactly with the golden rule. The proportion of length to width is precisely correct, which is why one can take them as a measure. And again, we have this unpleasant contrast line. It cannot be changed completely, as this would also require some modifications to the mandible. Therefore, this line is lifted slightly to finally change the contrast line. This is relatively difficult here, as we're dealing with a crossbite. Nonetheless, even with this crossbite, the upper teeth can be arranged somewhat buccally and so improve the optical situation. It's important that the final result should actually always look better than the diagnosis. We start with the initial situation. This is followed by the diagnosis, where we apply composite and make a model. Then we have the final situation with the smoother and more attractive surface, naturally, the way it should be. In this initial situation, we can also see the bow-like incisors and the sunken cuspid, which makes the entire dental arch appear somewhat unruly. Here you can see the diagnosis, and in the final outcome, the whole situation has been rounded off. I'll give you a classic example to show you how ideal componeer are suited for this procedure. This is a young girl, 17 years old. Of course, at this age, one does not perform any too severe interventions, but it serves well as an example. You can see we have a broad smile and the corners of the mouth are relatively far to the outside, making the first molars visible. At the same time, the teeth are relatively steep. This makes the dental arch actually appear too small for the mouth. This is quite a common situation. So, what was done here? We used componeer for diagnostic purposes only. Without conditioning the teeth, componeer was placed on the teeth and excess removed and light cured. This means that the componeer can be removed later with a scaler, entirely without damage. This example was a good demonstration to show that componeer have the ideal shape to complement own teeth. This also shows that if you wanted teeth, you can also restore them without preparation. Theoretically, one could alter the entire presence with bonded componeer entirely without preparation.